Hi, I'm Dr. Sarah Robertson, and I'll be presenting on clinical drug interactions. As part of this presentation or lecture, we'll first identify the different types of drug interactions. Next, we'll go into a little bit of detail about the principal mechanisms behind the most common drug interactions, including those that involve metabolizing enzymes and transport proteins. We'll talk about the appropriate interpretation and recognizing the clinical significance of drug interactions, talk about some complex drug interactions, focusing on interplay between drug transporters and metabolizing enzymes. And finally, we'll talk about how to efficiently access drug interaction information and how to interpret drug interaction information from product labeling. So as an overview, we'll start with the epidemiology, then talk about the mechanisms affecting drug absorption, distribution, metabolism, transport proteins, and elimination as they relate to drug interactions. We'll again talk about enzyme transporter interplay and some complex drug interactions, and then talk about the clinical interpretation. I provided some abbreviations that can be used as a reference. I will be referring to these in abbreviated form throughout the lecture. So to start with the epidemiology, it's very difficult to actually pinpoint the true incidence of drug interactions, particularly clinically relevant one. Most publications focus on retrospective review of medical record data. And it's difficult to know using medical records when patients are on concomitant medications and what the clinical significance really is. One helpful publication, though, reviewed nearly 9,000 Medicaid records over a 5-year period, and they looked specifically at clinically relevant drug interactions, because as we know, many aren't clinically relevant, and they found nearly 17% of the patients had at least one clinically significant drug interaction. Also, we think about newer drugs as being sort of screened out for a high propensity for drug interactions, because now modern screening techniques in drug development, you can identify early on agents that might have a propensity for causing drug interactions, and they tend to not make it through drug development. However, a recent review by the FDA of NDAs approved in the year 2013 found that 3/4 of them were metabolized by at least one cytochrome P450 or CYP enzyme. The majority of them metabolized by CYP3A, which we'll talk about, is probably the primary cause of most clinically relevant drug interactions. Also, the majority of them, 77%, showed a propensity to inhibit or induce enzymes in vitro, and 85% were found to cause a potential interaction via transport proteins in vitro. So overall, this suggests that although we are better at screening compounds early on, there's still a propensity for clinically relevant drug interactions, even in modern drug development. So there's two primary types of drug interactions. Those we call pharmacodynamic, and those are when two drugs interfere with each other's site of activity, whether it be a site of a safety or toxicity, or the site of activity or efficacy. Pharmacokinetic, on the other hand, is when two drugs interfere with the way they're metabolized or eliminated from the body. That is, they impact the way the exposure of the drug in plasma. So pharmacodynamic, most frequently those in which they're additive to a toxicity, and those most frequently identified in the Nelson review we just talked about are things in which antipsychotic seizure medications or sleep disorder medication, things which can cause dizziness or somnolence. Those are additive toxicities, and those are very common among what we call the pharmacodynamic interactions. Pharmacokinetic, as I alluded to, are most commonly caused by inhibition or induction of metabolizing enzymes, CYP450 enzymes in particular. So first, to talk about the pharmacodynamic interactions, again, I talked about additive combinations. There's also synergistic or antagonistic combinations. An example of a pharmacodynamic interaction, an additive effect, is a very common one, that between ibuprofen and acetaminophen. They're often used in combination to provide additional analgesic effect. One harmful example is that of zidovudine, an anti-HIV medication, and ganciclovir, which is an anti-CMV or cytomegalovirus agent. They are frequently used in combination in the treatment of AIDS. Patients that have CMV both cause neutropenia, so in combination they can cause an additive or worsening of the neutropenia. An example of a synergistic combination that's beneficial is that of aminoglycosides with penicillin or vancomycin. So together these agents are used for the treatment of gram-positive infections because the cell wall agent vancomycin or penicillin allows the aminoglycoside access inside the cell wall. An example of a harmful synergistic combination is that of barbiturates and alcohol. Antagonistic combinations, again, are those in which One competes with the other for binding site, for instance, or interferes with the target for activity. Beneficial example is that of naloxone or Narcan, which is used frequently in the treatment of acute opiate overdose. A harmful antagonistic combination is that of zidovudine and stavudine, again, two anti-HIV drugs that compete with each other for the same site of phosphorylation or activation. So moving on to pharmacokinetic interactions, which are the most common mechanism of which when we talk about drug interactions. And again, we're talking about when one drug interferes with the way another drug is absorbed, the way it's distributed throughout the body, the way it's metabolized, transported throughout the body, or eliminated, thereby affecting its plasma concentrations or exposure. So we'll go into each one of these mechanisms in a little more detail. Starting with absorption, many drugs are dependent on a specific pH range for optimal solubility. Not all drugs, but many drugs are. So when you increase the gut pH by using an H2 antagonist or a proton pump inhibitor, it can interfere with, either increase or decrease the solubility of a drug depending on its solubility profile, thereby increasing or decreasing absorption. So some examples of these are, all of these examples actually use omeprazole, very common proton pump inhibitor. Frequently, when we want to evaluate the effect of pH in a drug, we'll do a drug interaction study using omeprazole. So in these examples, atazanavir and raltegravir, two both anti-HIV medications, when combined with omeprazole, you see opposite effects. Atazanavir exposure, or AUC, was decreased by almost 100%, whereas raltegravir's exposure increased threefold. Now, I also like to point out the clinical relevance here, because again, it's not always immediately apparent what the clinical relevance is. So raltegravir, although exposure increased threefold, actually has quite a wide therapeutic index. So that threefold is really not an issue, and you can dose raltegravir with proton pump inhibitors, H2 antagonists, and there's no issue, and that's clear in the product labeling. Atazanavir, on the other hand, if you decrease exposure by 94%, has a profound impact on the efficacy of that medication, and it can actually result in resistance of HIV to the atazanavir and the class of drugs in general, protease inhibitors. So again, product labeling reflects that and recommends not to co-administer with proton pump inhibitors. Another example here is orlatinib, which is an anti-cancer agent. It's used to treat pancreatic cancer and non-small cell lung cancer. Now, with proton pump inhibitors, we saw a 50% decrease in the exposure of the drug, which on first glance might leave you with the impression that that's not particularly clinically relevant, a 50% decrease. However, a retrospective review went back and looked at patient records and found that those individuals that were on a concomitant acid-suppressing agent, such as a proton pump inhibitor, actually had shorter overall survival of nearly 4 months after accounting for all other covariates that could have contributed. So this is another nice example about looking at a magnitude of a drug or an interaction. It's not immediately apparent what the clinical relevance is. It really depends on the therapeutic margin of the agent. Another mechanism by which drug interacts affecting drug absorption is those drugs which affect GI motility. Most common are opioids, for instance methadone, which slow down our GI transit time. And it can affect drugs to varying extent depending on where in the GI tract the drug is absorbed based on its solubility, permeability profile, and other things. In this example, I have didanosine on the left-hand side with methadone, and you can see profound decrease in didanosine absorption. Because of the decreased motility, there was additional breakdown of or degradation of didanosine in the GI tract. On the other hand, metoclopramide increases GI motility. That's where its mechanism of action comes from. And it can sometimes decrease absorption of certain drugs, again, depending on how much time they need for absorption in the GI tract. However, one study done here with posaconazole shows just a very mild decrease in exposure of that antifungal agent. So really not a clinically relevant interaction. These interactions impacted by GI motility are very hard to predict, and you generally need a drug interaction study to be able to demonstrate the impact. A third mechanism affecting drug absorption is chelation. And the drugs we most commonly think of here are tetracycline and quinolone antibiotics, in which they bind to a di or trivalent cation in the GI tract and inhibit the absorption of those drugs. Usually this can be overcome by separating the administration of the ion. These are things that are typically found in multivitamins or in antacids. So in this example here with trovafloxacin, a quinolone antibiotic, You can see when administered alone relative to co-administration with Maalox just 30 minutes before the trovafloxacin, there was a big impact on exposure of trovafloxacin. However, if the Maalox was given 2 hours after, there was a negligible effect on the absorption. And we know it's not a pH effect because trovafloxacin was also administered with omeprazole, and you can see the concentration time profile is nearly superimposable there. So we'll move on and talk briefly about drug transporters as they relate to GI bioavailability. So drugs are taken up by cells. Every drug has a different permeability. And depending on that permeability, they may rely more or less on uptake proteins such as the OATP proteins, OATP 1B1, 1B3 being some common ones. There's also efflux proteins in the GI tract specifically, but we'll talk about other organs later on. And those drugs in which there's not a very high permeability, their bioavailability can be very susceptible to the efflux proteins, such as P-glycoprotein or PGP, which we'll talk about quite a bit throughout this lecture. So this schematic shows a little bit about what happens when drugs permeate the cellular membrane. They can be effluxed back out if they're a substrate for efflux transporters. Likewise, they can be taken up by uptake proteins. Transport proteins in the intestinal lumen again include uptake transports and efflux transporters. When drugs inhibit or induce these transport proteins, they can thereby decrease or increase the bioavailability of drugs that are substrates or drugs that rely on these transporters. So if you inhibit, for instance, an efflux transporter, you would be increasing the uptake of the drug. And again, reliance on these uptake efflux transporters depend on the permeability of the compound in the gut. The lower the permeability, the more the absorption is affected by membrane transporters. Of the many gut transporters that have been identified, P-glycoprotein or PGP and breast cancer resistance protein or BCRP are the two that are most commonly associated with clinically relevant drug interactions. This schematic shows all of the transport proteins that have been identified in the gut. And I've circled here BCRP and PGP or P-glycoprotein. It's also commonly referred to as MDR1, which is the gene that encodes its activity. And again, if you block the efflux transporters, that is, you decrease or you block the efflux of the drug back into the gut, you'll increase blood levels of the substrate. So one classic example is that between quinidine and digoxin. Quinidine, we know, is a PGP inhibitor. It's quite a strong PGP inhibitor. Digoxin is what we call a sensitive substrate. So it's a substrate that relies on PGP. It's sensitive because just a small impact on PGP can have a relatively large impact on digoxin bioavailability or plasma concentrations. And we'll return to this concept of a sensitive substrate later on, because we tend to do our drug interaction studies with these sensitive substrates. We can characterize the worst case scenario or the biggest impact in the most sensitive substrates. So this is a well-documented drug interaction, and in one particular perfusion study, they documented a 2.5-fold increase in the amount of digoxin absorbed when it was given with quinidine. As I mentioned, digoxin DDI studies are often conducted. We want to characterize a drug's impact on P-glycoprotein or PGP. Other clinically relevant PGP inhibitors that have been well documented include cyclosporin, erythromycin, verapamil, and itraconazole, but there are many others. Now we'll move on to mechanisms of altered drug distribution causing drug interactions, to start with protein binding. So there's been a bit of a debate about the clinical relevance of protein binding drug interactions. It's mostly been described as a theoretical mechanism, mostly impacting restrictively cleared drugs, that is, those with only a small fraction of drug extracted as it passes through the organ, such as the liver. Only unbound drug is cleared from plasma. So if another drug is given that competes for protein binding and causes a lot of protein displacement, as the unbound fraction increases, more drug is eliminated. So I'll show on the next slide a cartoon that describes this a little bit better, or demonstrates this a little bit better. Again, this is described mostly as a theoretical. In general, it's generally accepted now that there's very few examples of very clinically relevant protein binding drug interactions. Warfarin is generally considered one at being higher risk because it's highly protein bound, it's got a narrow therapeutic index, and it's a restrictively cleared drug. However, in this cartoon you can see on the lower half we have warfarin concentrations, both total and free concentrations. On the upper half is a demonstration of the thrombin time, which is warfarin's pharmacologic activity, how we measure bleeding time. So as you can see, when the displacing drug is added, more free drug becomes available. However, as more free drug becomes available, not only does it increase prothrombin time, that is, increase warfarin activity, it also becomes eliminated quite rapidly. And as you can see then, total drug actually comes down to a new lower level, but the amount of free drug returns to its pre-displacement levels, and so too does the prothrombin time. So the impact in this case is actually quite narrow with respect to time, and again, the clinical relevance of it has been questioned. But you'll often see protein binding type interactions come up in searches or in tertiary references. Another mechanism is alteration of transport proteins into other organs other than the gut. We talked about the gut already, but there's a lot of other blood organ barriers, particularly the brain, placenta, kidneys, but there's many others. And transport proteins play a role in protecting those organs from drug exposure. So by inhibiting or inducing transport proteins in these other organs, we can increase or decrease drug exposure. So some examples listed here. For instance, when we give loperamide with quinidine, we can increase CNS penetration of loperamide by inhibiting PGP in the CNS. And of course, loperamide can have some CNS toxicities when we increase the exposure, such as dizziness and other things. And there's some other examples here, including digoxin penetration to the CNS, disipramide and its access to hepatocytes, and finally penicillin and probenecid, penicillin excretion in the kidneys. So let's move on now to metabolism. Here's a brief overview of the principal metabolic routes. We talk about phase 1 and phase 2 metabolism. Phase 1 includes the CYP450 or the cytochrome P450 enzymes present in both the gut and the liver. It's our primary source of most adverse drug interactions, so we'll spend quite a bit of time talking about the CYP450 enzymes. The phase 2 enzymes are the conjugating enzymes, such as UGTs, methyltransferases. These are less associated with clinically relevant drug interactions, in part because there's quite a amount of these enzymes available. So in order to inhibit the enzyme and cause a clinically relevant increase in drug exposure is actually quite rare because of the relatively larger quantity of enzymes available. So we'll focus on phase 1. Inhibition of the CYP450 enzymes can occur in the liver or in the GI tract. CYP3A in particular, most prevalent of the CYP450 enzymes, is predominantly available in the GI tract. When we inhibit CYP450 enzymes, we increase exposure of the substrate because we've reduced its metabolism. The biggest concern with this is increase in toxicity with higher plasma concentrations of drug. This is typically through competitive binding to the enzyme site. The onset and offset generally is relatively quickly, and the time to steady state or maximal effect is the time it takes for our substrate to get to steady state. And I'll show that in a cartoon in the next slide. So here you can see we're at a steady state of a substrate concentration, with the concentration on the y-axis and time along the x. And then we add the CYP inhibitor, and you can see the substrate drug accumulate in plasma. And as it accumulates, it reaches a new steady state, and it may be some level of 2-fold, 4-fold, or even 20-fold higher than the original concentration. It depends on the magnitude of the inhibition, and I'll show some examples shortly. So in general, if a substrate relies on only one metabolizing enzyme for its elimination, such as midazolam, it's extensively metabolized by CYP3A. It's only metabolized by CYP3A. It's its sole route of metabolism. So if you inhibit that route, there's a real profound effect on metabolism exposure. Contrary to that, there's drugs such as voriconazole that rely on many CYP450 enzymes, 3 in the case of voriconazole. So if you inhibit CYP3A, it still has other routes by which it can be eliminated. So there's less of an impact on voriconazole when you inhibit one particular route. We talked about competitive-based inhibition, but there's also mechanism-based enzyme inactivation. And this is when there's a reactive metabolite form that can bind covalently to the enzyme, effectively shutting it down. Results in an irreversible, or what we call quasi-irreversible, inactivation of that CYP enzyme. It tends to be more of a profound and more of a prolonged inhibitory effect relative to the competitive route. Some examples of drugs that cause mechanism-based enzyme inactivation include grapefruit juice or the macrolide antibiotics, such as clarithromycin. The duration of this type of inhibition generally depends on the time needed for the enzyme to restore itself. So this can be quite prolonged after you remove the inhibitor. Here's an example with ritonavir by the brand name Norvir. This is a relatively common agent in HIV medications. It's used to actually boost other protease inhibitors in a combination regimen. It's often regarded as a PK booster because it is a profound 3A inhibitor. And here you see on the left what happens with triazolam. Triazolam, much like midazolam we described as a sensitive substrate, is metabolized extensively and exclusively by CYP3A. So when you give a strong inhibitor like ritonavir, you see a 20-fold increase in exposure of triazolam, which is quite profound. On the other hand, zolpidem, also known as Ambien, is metabolized only partially by CYP3A. It's also metabolized by other CYP enzymes. When you combine it with ritonavir, you see only a 28% increase in exposure. So now we'll move on to enzyme induction. So unlike inhibition, induction involves activation of the DNA transcription via activation of a nuclear receptor, most commonly PXR or CAR activation. And by activating these nuclear receptors, it results in synthesis of new CYP enzymes. Enzymes results in more metabolism. You're inducing the metabolism of a drug. By increasing the metabolism of the drug, you get lower exposure, so the opposite of what we observed with inhibition. Relative to inhibition, induction generally is a slower onset and offset, and depends on the half-life of the inducer. It also depends on the time it takes for new CYP proteins to be made or degraded after you remove the inducer. Again, it results in decreased substrate, so generally associated with reduced activity or loss of efficacy of our substrate. And again, when we remove the inducer, if we've compensated by increasing the dose of the substrate, we can get toxicity if we don't reduce the substrate back to its original dose. So we have to think about the addition as well as the removal of an inducer. And unlike inhibition, where it depends on how many metabolic routes the substrate uses, induction can be significant even when a particular substrate relies on more than one CYP enzyme for its elimination. So here's a cartoon demonstrating induction. Again, we're at steady state for a particular substrate, looking at the concentration time profile. And we generally think of induction as taking about 2 weeks to increase or to decrease substrates to reach a sort of steady state. At the end of 2 weeks, we generally think of the full effect of induction as having taken place. And again, we'll then have reached a new steady state for the substrate in the presence of that inducer. And again, it could be only a 20% decrease. It could be an 80 or 90% decrease, depending on how strong our inducer is. This is an example with rifampin. Rifampin is regarded as a very strong inducer of CYP3A. This was a study done with another anti-TB drug, an investigational agent, since it was intended to combine these compounds for the treatment of TB. This drug interaction study was done early on in development, and it was found that rifampin decreased the exposure of this investigational agent quite significantly. It decreases the AUC by 66%. And as you can see in the concentration time profile, the half-life was considerably shortened because the drug is being eliminated so much faster. So this has implications for how this drug would be dosed in combination with rifampin throughout the course of development. This table shows some common CYP450 inhibitors and inducers as a reference. So now we'll talk a little bit about transport proteins and hepatocytes and biliary elimination. So look, as we talked about transport proteins in the gut, there's also transport proteins and hepatocytes. There's some that cause uptake into the hepatocyte, and those are generally the OATPs, as we think of being associated with more clinically relevant drug interactions, though there have been many more that have been identified. The OATPs are those that we generally think about. You inhibit uptake into the hepatocyte, you get increased plasma concentrations of your substrate drug. Likewise, we have efflux transporters on the biliary side of the hepatocyte, which excrete drug into the bile, particularly those drugs that are not extensively metabolized, might be excreted unchanged into bile. And if we inhibit those efflux transporters, again, BCRP and PGP being the two main players here, you can get increased plasma concentration, decreased elimination from the body. This is an example of a drug interaction caused by inhibition of hepatic transport proteins. OATP1 and OATP2 enzymes are inhibited by gemfibrozole. In this example, gemfibrozole was co-administered with rosuvastatin. Rosuvastatin is generally regarded as a sensitive substrate of the OATP transporters in hepatocytes. And you can see gemfibrozil caused nearly 90% increase in exposure of rosuvastatin. So here's where we're going to talk a little bit about transporter-CYP interplay. So in the example here we have atorvastatin. Atorvastatin is a substrate for CYP3A metabolizing enzymes. It's also a substrate for the transport proteins PGP and OATP 1B1 and 2B1. So starting at the bottom, when we combine atorvastatin with only gemfibrozil, which is an OATP inhibitor, you see a relatively mild increase in exposure, only 35%. As we move up though, when you combine it with diltiazem, which inhibits both PGP and moderately inhibits CYP3A, you see a larger impact on atorvastatin because now we're inhibiting the efflux out of hepatocytes as well as inhibiting the metabolizing enzyme. As we move up, clarithromycin also inhibits PGP, but it's a stronger CYP3A inhibitor. We see nearly 4.5-fold increase in atorvastatin exposure. And finally, cyclosporin, which inhibits multiple drug transporters and is quite a strong inhibitor of the OATP and PGP transporters, you see an almost 9-fold increase in atorvastatin exposure. So this is what we talk about when we say transporter-CYP interplay. When you have agents that inhibit more than one transporter or inhibit a transporter and a metabolizing enzyme, you can often see much bigger impact on substrate exposure than you might otherwise see with just an inhibitor of one particular pathway. And these are very often difficult to predict, and you require a clinical drug interaction study to be able to describe the impact. So we'll move on to altered renal elimination. And again, transport proteins are the primary route by which we see renal drug interactions. The OCT and OAT transporters on the blood portion cause uptake into the renal tubular cell. When you inhibit these uptake transporters, you can get increased plasma concentration. So OAT transports anions, OCT transports cations primarily, and PGP again can efflux out of renal tubulars into urine. So inhibition of the efflux could increase potentially renal toxicity within the renal tubular cell, or it could increase plasma concentrations. Some examples here are cimetidine, which causes an increase in metformin and pramipexole exposure. Another one is probenecid. That's a very classic inhibitor of OAT transporters in kidney cells. And it can increase the concentration of multiple drugs, notably cidofovir, furosemide, acyclovir, also penicillin is another one. So let's talk a little bit about complex drug interactions. We talked about transporter enzyme interplay, which can also result in complex drug interactions. Some agents can also cause inhibition and induction of a particular enzyme at the same time. Ritonavir is a classic example. It's a stronger CYP3A inhibitor, but it also causes some induction, which can result in unpredictable or time-dependent effects on a substrate. For instance, if you give a drug shortly after you start ritonavir therapy, you'll see a very profound increase in exposure. But over the course of the next several weeks, as the induction kicks in, that inhibition will be lessened a little bit, and you actually see less of an effect several weeks into ritonavir therapy relative to within the first few days of treatment. Also, we can have concurrent inhibition or induction of a particular enzyme and transporter at the same time, and that's what we talked about a little bit already with respect to the complex interplay between transporter and enzyme. You can have a combination of inhibitors with different enzymatic paths used by one substrate. So in other words, if we're inhibiting CYP3A for voriconazole, we may not see much of an impact. We talked about the other routes it uses. If we add a second drug that inhibits now 2C9 or 2C19, we might just get to see a more gradual increase in voriconazole exposure. So we have to think about all of the drugs that a particular patient is taking. Also, some of the metabolizing enzymes are polymorphic, that is, they're expressed to different degrees depending on somebody's genetic makeup. So one polymorphic enzyme in particular is CYP2C9 we think of, and poor metabolizing CYP2C9 is more prevalent in Asian population, for instance. So an agent such as voriconazole that might rely on 2C9 and CYP3A, in a poor metabolizing CYP2C9 patient, the voriconazole may rely on alternate routes instead of CYP2C9. But if we give a CYP3A inhibitor, it can therefore have a more profound effect on voriconazole than it might otherwise have in a CYP2C9 extensive metabolizer patient. There's a few examples where drugs are labeled specifically with drug interaction information for particular genetic polymorphisms, such as CYP2C9. And then, this is very difficult to predict, but patients with altered renal or hepatic elimination because of kidney or liver disease can be particularly susceptible to drug interactions. And this is very difficult to study, but it's important to keep this in mind. These patients in general are a more vulnerable patient population and more susceptible to not only drug toxicities, but to drug interactions in general. So how do we predict clinical drug interactions? Well, it starts very early in drug development. We do a number of in vitro experiments using recombinant CYP enzymes, liver microsomes, hepatocytes, or liver slices. And we use these to characterize first the method by which a drug is eliminated. Is it extensively metabolized? And if so, which enzymes are responsible for its metabolism? If it's renally eliminated, are there transport proteins that are involved in that renal elimination? And if it's excreted in bile, are there efflux transporters involved in the efflux into bile? After we've characterized how the drug is eliminated, this essentially describes the drug's potential as a victim drug. So if it's a CYP3A substrate, then we need to start thinking about which CYP3 inhibitors or inducers might it be co-administered with. After we've characterized the drug as a substrate or as a potential victim, then we determine whether the drug has the potential to inhibit or to induce enzymes or transporters. This describes the study drug as a potential perpetrator. And after we've described all these things using in vitro experiments, then we can start to relate it to the clinical likelihood of this actually happening. And generally what we do is we use in vitro constants like the IC50, or the concentration required for 50% of maximal inhibition, to predicted in vivo clinical concentrations, such as the Cmax or peak concentration. Often we'll put this in terms of I over the IC50. The FDA has a generally conservative look when relating in vitro data to in vivo predictions. And if it looks as if there may be a chance for a clinically relevant drug interaction, they'll often ask that a company conduct a clinical DDI study, in some cases simply to rule out the interaction. More recently, there's been a lot of research focused on mechanistic modeling. This is an in silico method by which we can model what the physiologic system is. We can look at drug transporter, we can look at metabolizing enzymes, and by plugging in some of the in vitro data that we get, we can make some reasonable estimations or predictions of what we might expect to see in vivo. And in some cases, we can do this in lieu of a clinical DDI study. So once we've characterized a drug interaction potential using in vitro data, then we may start conducting some clinical DDI studies to rule out or to characterize the impact of a drug interaction. Initially, what we call probe studies are done. So we use a probe such as a strong inducer that's been well characterized, like rifampin. Again, if we know our study drug is a CYP3A substrate, we may do a phase 1 DDI study in healthy volunteers characterizing the effect of rifampin on exposure of our study drug. We may use something like itraconazole, which is a strong CYP3 inhibitor. Again, this is a probe drug. It's well characterized as a strong inhibitor of CYP3A. We can also evaluate our drug as a potential perpetrator, and again, we use probe drugs or sensitive substrates that have been well characterized, such as midazolam for CYP3A, digoxin for PGP, or rosuvastatin for OATP is another example. And depending on the results of these initial studies, then we think about other DDI studies that might need to be conducted, such as likely co-administered medications. Potentially we'll look at moderate or maybe even weak inhibitors or inducers of transporters or metabolizing enzymes. We might look at drugs with mixed enzyme or transporter effects. And this is too when we start to think about other things like pH-dependent solubility and whether we need a study with a proton pump inhibitor. When evaluating the risk in the clinical setting, we have to think primarily about the therapeutic index of the victim drug, or the substrate in this case, because a 50% increase or decrease in exposure doesn't mean the same thing for every drug. For instance, atorvastatin is not likely. We wouldn't consider a 50% increase in atorvastatin is a very clinically significant increase. It's got a relatively wide therapeutic index, versus a 50% increase in tacrolimus, for instance, which is used for organ rejection. a 50% increase could have clinically significant implications. Notably, it causes nephrotoxicity, so 50% increase could be clinically significant. We have to think about, are there other perpetrators involved? And again, we have to review the entire list of drugs that a particular patient is on. We have to think about the likely time course of the interaction, both the onset and the offset when we withdraw drugs from a particular patient. And we have to think about the DDI as a class effect and consider other options. For instance, rosuvastatin and simvastatin have very different therapeutic indices. Increase in simvastatin exposure, for instance, can have some toxicity issues whereby rosuvastatin doesn't necessarily have those implications. So it just depends on the agent. You have to think about the therapeutic class, and there are other things in that class that could be used in lieu of the particular agent that's subject to the DDI. Sometimes DDIs are a class effect and sometimes they're not. Rosuvastatin and simvastatin have very different substrate specificities and enzyme specificities. We also have to think about if there's other confounders that might magnify the DDI. And again, this would be organ impairment, renal or hepatic impairment, or older age. So let's talk a little bit about U.S. product labeling. Drug interaction information appears in a few sections of the product label. I've highlighted here in bold. Most specifically, Section 7 is really focused on just specifically on drug interactions, so it provides a lot of information, results of drug interaction studies, but also the clinical interpretation. But you might also find that information on dosage and administration if there's a particular dosing recommendation to be made in the setting of a drug interaction. And then Section 12, clinical pharmacology, gets into a little more detail about the particular results of studies that have been done. So in this example, I've used Kalydeco ivacaftor used for the treatment of cystic fibrosis. And in Section 7, it describes the impact of inhibitors of CYP3A. Ivacaftor, like midazolam, is extensively and exclusively metabolized by CYP3A. It's a sensitive CYP3A substrate. So that's described here in Section 7. And then it also goes on to describe the impact of ketoconazole, a strong CYP3A inhibitor, on ivacaftor exposure, and how the dose should be reduced in the setting of concomitant strong CYP3A inhibitors. Likewise, fluconazole, which is only a moderate CYP3A inhibitor, also increased ivacaftor exposure by threefold, and so there's also dosing recommendations when co-administering ivacaftor with moderate CYP3A inhibitors. So all of this information appears in Section 7. It also goes on to warn against using grapefruit juice or drinking grapefruit juice or consuming Seville oranges during treatment with ivacaftor because of the CYP3A inhibition potential. This drug product also has information in Section 7 about CYP inducers. A study was done with rifampin, which caused a approximately 9-fold decrease in exposure. So it warns against co-administration with strong CYP3A inducers and lists a few examples. And then Section 12 really provides a full layout of the drug interaction study results. Section 12 will usually contain either a table or, in this case, a forest plot in which you can compare the impact of interacting drugs that were conducted for a particular compound. And lastly, I provided here in a table some resources or tools, some tertiary references that can be referenced when you're looking for information. Some of these are specific to HIV medications, such as UCSF's website. Martindale's or Micromedics is a great general reference. The University of Washington provides a drug interaction database, which is extensively referenced. It's actually an excellent reference. The FDA uses it quite considerably in their guidance documents and in their websites because it's so extensive and comprehensive. Thank you.